Hello, and welcome to the Society of Critical Care Medicine's iCritical Care podcast. I'm your host, Dr. Margaret Parker. Today, I will be speaking with Michael A. Smith, MD, on the article Outcomes of Children with Cystic Fibrosis Admitted to PICUs, published in Pediatric Critical Care Medicine. To access the full article, visit pccmjournal.org. Dr. Smith is a Pediatric Critical Care Medicine Fellow in the Department of Pediatric Critical Care Medicine at the University of California in San Francisco, California. Welcome, Dr. Smith. Do you have any disclosures to report before we start?
Hi, Dr. Parker. Thanks so much for having me. No disclosures to report on my end.
Okay. Would you start by giving us some background on what led you to do your study looking at CF in PICU patients?
Absolutely. So, as I'm sure many are aware, there's been a lot of progress made in the realm of CF management in recent years. The development of new disease-modifying therapies, new respiratory support technologies, both being used in the hospital and available for patients at home. And with all this progress, there's been pretty significant advances in outcomes for CF patients overall. There's been a pretty steady increase in the median age of survival for CF patients. In the last 20 years or so, it's gone up about 16 years to a median survival age of now close to 50. And although I knew how severe the disease can become in some cases, I had pretty minimal personal experience with taking care of critically ill children with cystic fibrosis. So just out of curiosity, myself and some of the people I collaborated on this work with took a look into the literature, and were pretty surprised to find that the literature on this cohort of CF patients is pretty scant. There's only been a handful of studies that have reported on outcomes of critically ill CF patients, and few focus on children. So what we did see was kind of surprising, that there were mortality rates ranging anywhere from 35 all the way up to 100% in some small studies. And one of the more thorough studies that we saw in that initial literature review was from all the way back in 2002, and only included 33 patients with a reported mortality of 61% of all these patients were mechanically ventilated. So seeing how little literature there was published recently on this cohort of patients, and knowing how significant the advances in the care of the CF patients overall has been in recent years, we thought it'd be interesting to try to look into and gain a more updated understanding of this specific cohort of CF patients.
So tell us how you did your study.
So we ended up we performed a retrospective analysis that looked at data that we pulled from the Virtual Pediatric Systems, the VPS database. VPS is a data set that collects data from I think it's close to 130, 140 different pediatric ICUs, anything from demographic data, some clinical data, data on procedures used, etc. And we ended up looking at close to 3,000 admissions of a little over 1,600 patients with cystic fibrosis, patients who were admitted from the beginning of 2009 to about midway through 2018. We focused on a primary outcome. We just decided to focus on survival to PICU discharge. And then we calculated odds ratios of mortality in both univariate and multivariable models to assess for significant predictors, looking at those variables such as demographics, anthropometric data, some clinical characteristics, associated diagnoses along with CF, as well as the need for procedural interventions. So that was basically the gist of our study design.
What risk factors did you look at?
So we used like I mentioned, a fair bit of demographic data. So age, racial and ethnic background. We looked at some um, hospitalization characteristics, including where patients were admitted to the ICU from, so were they transfers from the floor, from the ED, from other ICUs, et cetera. We had a fair amount of data from PRISM-3, the risk of mortality scores, that we included in our analysis. And then the bulk of the analysis was on associated diagnoses. So we looked at all of the patients were selected into the cohort if they had a diagnosis code for cystic fibrosis attached to the specific hospital admission, but then we additionally included comorbid diagnoses in our analysis. And then lastly, we looked at a number of different procedural interventions. So the need for non-invasive and invasive ventilation, chest tube insertion, bronchoscopy, the need for renal replacement therapy, ECLS, et cetera.
How did you handle multiple admissions? Obviously, a lot of these kids come back more than once, sometimes for similar or often for different reasons.
Yeah, absolutely. And we certainly saw that. We had, like I mentioned, close to 3,000 admissions, but only a little over 1,600 individual patients. So a good number of them were admitted multiple times during the study period. In order to account for the multiple admissions and to ensure that certain variables weren't more heavily weighted or unduly weighted because of the multiple admissions, we used generalized estimating equations that clustered on a patient-specific identifier that was consistent with each subsequent admission, so that again we weren't unduly accounting for that certain data for repeat admission.
So tell us about your findings.
Absolutely. So firstly, we ended up calculating an overall mortality rate of 6.6% of admissions, or if looking at the total number of patients, 11.8% of the patients involved in the study. And then we additionally did kind of a subgroup analysis. We looked at just the patients who underwent mechanical ventilation, and in that group, we saw a mortality of 19.1%. And then looking at what factors were associated with mortality, there were a number of specific comorbid diagnoses. So things like hemoptysis, pulmonary hemorrhage, pneumothorax, GI bleeding, hepatobiliary disease. We saw increased mortality with bacterial and fungal infections, so not with viral infections. And then interestingly, we saw an increased mortality associated with diagnoses pertaining to malnutrition, as well as in those patients in which we could calculate a BMI, so a relationship between lower BMI and increased mortality. And then, not unexpectedly, saw increased mortality for patients who required both invasive and non-invasive respiratory support. There were a couple of kind of interesting factors that, or interesting variables that were not associated with mortality that were a little bit surprising to us. A couple of which being sex and racial or ethnic background, even despite there being pretty well described differences in both CF genotypes and the rates of morbidity and mortality between these groups as a whole. It didn't seem like those persisted, at least in our cohort, in the critical care or critically ill population. And then like I mentioned, we also did that stratified analysis of mechanical ventilation, because a lot of the previous reports focused specifically on patients who are mechanically ventilated in the ICU. And I thought one of the more interesting findings that we had was that of the non-survivors, the people who passed away during the study time period, there were about close to 21% of admissions that did not include an intubation or mechanical ventilation. So presumably these were patients who had some form of limitation of care in place, either a DNR or specifically a DNI order.
Did you have any information on the decisions to limit care, or could you identify any differences between the non-survivors who did versus those who did not receive mechanical ventilation?
Yeah, unfortunately, I'd say one of the limitations of our study is that we did not have specific information on what limitations of care might have been in place for a given patient or during a specific admission, which would have been an interesting variable to include in our analyses. There were some interesting differences between those who did and did not undergo mechanical ventilation prior to death. One being the patient origin, so where they were admitted to the ICU from. There was a higher likelihood of patients who did receive mechanical ventilation having been admitted either from the OR following the procedure or as transfers from another ICU, whereas those who did not receive mechanical ventilation prior to death were more likely to have been admitted from the emergency department or transfers from a general pediatric ward or an intermediate care unit. And then I think not unsurprisingly, there were higher rates of comorbidities, renal and cardiovascular comorbidities in the non-survivors who were ventilated prior to death, and then higher rates of other procedural interventions, so chest tube insertion, bronchoscopy, etc. There was essentially zero other procedures performed in patients who did not receive mechanical ventilation prior to passing away, which again leads us towards that assumption that these were patients who had some limitations of care in place.
Which would be a reasonable assumption to make. Were you able to look at things like BMI? Were these kids who were more cachectic, perhaps, or later in their stage of the disease?
Speaking to specifically about those who were did not receive mechanical ventilation prior to death, is that your question?
Yes.
That did not end up being significant in our in that subgroup analysis. The relationship of low BMI or malnutrition being associated higher in the group who were not ventilated prior to death, as opposed to those who did receive mechanical ventilation prior to passing away. But we did see, overall, that lower BMI was associated with increased mortality.
You mentioned that one of the limitations of your study was that you did not have information on advanced directives. Can you talk about other limitations of this study?
Yeah, absolutely. One of the main issues that we dealt with was just the fact that DPS is kind of designed as a critical care database, so it was lacking some of the key data that's used often in CF research, particularly CF mutation data and pulmonary function testing results, etc. And then it also, unfortunately, lacks data on mortality outside of the ICU. So, particularly in the case when you're looking at patients with limitations of care in place, you may be masking some of the mortality for those patients who may transfer out of the ICU prior to their death. And then, lastly, though it was certainly a strength of our study, I felt that we had collected so much data over such a long time span. We weren't able to actually look at specific dates of admission and stratify by date of admission to study how outcomes changed over the course of the 9 years of data that we studied. And one of the impetuses for the study in the first place was to see how these outcomes have changed in recent years. And we collected so much data that it would have been interesting to see within the data we had how things had changed.
So, what do you think the implications are of your study for the pediatric critical care practitioner?
Well, first off, I think it's just important to recognize that outcomes for the critically ill CF patients, like those for the CF population as a whole, have improved pretty significantly from prior reports. And, though it's still high, specifically in the subset of CF patients who end up intubated, it's much improved than what was previously reported. And I think that piece in particular is important to take into consideration, both when trying to decide in a specific clinical scenario, whether or not to intubate, mechanically ventilate, et cetera, but also when counseling patients and families and making decisions on limitations of care. I think it's just important to have an updated epidemiological insight into to help inform your discussions with patients and their families. And then I think also I feel like we hopefully highlighted the importance of really good, strong chronic disease management outside the ICU and even outside the hospital. Some of the things we mentioned already, like malnutrition and other kind of non-pulmonary comorbidities, were really strongly associated with ICU mortality. And so these are things that, as ICU physicians, we can use on admission of CF patients to gauge kind of the baseline severity of disease, and then should also be things that we kind of keep in mind to do our best to set patients up who are leaving the PICU to have success in these realms to prevent poor outcomes in future admissions.
What additional studies would you like to see done in this population? Where should we go next?
I do think there's like we mentioned already, some interesting work to be done looking at the approach to establishing limitations of care in this population, and that, of course, is ideally done before the pediatric ICU admission, but would be interesting to look at the sorts of factors that should be weighed in, or that weigh into those sorts of conversations and how they affect decision making in the ICU setting. And then I haven't mentioned it just yet, but we had some interesting analyses that looked at the subset of our cohort that had diagnosis codes that indicated a post-lung transplant status. And we actually, very interestingly, saw no relationship between mortality and post-lung transplant status in our group of patients, which we really didn't have the power to kind of explore further. But I think it would be really interesting to do another similar sort of study looking at outcomes in the pediatric ICU, specifically for those patients who have received lung transplants. In the era that we're doing more and more lung transplant for the CF patients, I think it'd be really interesting to understand how they do post-transplant.
Do you have any final comments you'd like to make?
No, I really appreciate you having me on, Dr. Parker. This was really interesting, and I appreciate you giving some time to highlight some of the work we did on this interesting and unfortunately not as studied subset of the cystic fibrosis population.
Well, I think you have contributed substantially to what we understand about these kids, and demonstrating, the mortality rates have come down so much. I think that this is really interesting work, and I congratulate you on carrying it out.
Thank you so much.
We have been talking today with Dr. Michael Smith from the University of California, San Francisco School of Medicine about the article Outcomes of Children with Cystic Fibrosis Admitted to PICUs, published in Pediatric Critical Care Medicine in January 2020. This concludes another edition of the iCritical Care podcast. For the iCritical Care podcast, I'm Dr. Margaret Parker.
Margaret Parker, MD, MCCM, is Professor Emeritus of Pediatrics at Stony Brook University in New York. She is a former president of the Society of Critical Care Medicine. She is currently serving as Associate Editor of Critical Care Medicine and Senior Associate Editor of Pediatric Critical Care Medicine. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants, and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.